Hi everyone, this is Neil Wright, consultant audiologist and director of Clearwax. Thank you for joining me in my latest video using the iClearScope endoscope. And here we have a patient who attended with bilateral blocked ears. I'm just commencing with their right ear first. They have to attend periodically, almost every 3 months. When I first saw this patient a few years ago, they attended with the most severe case of otitis externa. In this right ear in particular, the ear canal was so swollen, it was so difficult to even insert the instruments, but we did manage. And one of the triggers of this patient's infections was that they were prone to getting water in their ears. And after I advised them to be a bit more careful and just either consciously avoid getting water in the ears when you're showering or when you're swimming or bathing, and if that's not possible, just to place a simple piece of cotton wool, not inside the ear per se, just at the entrance, and you can apply some Vaseline around the edge to help create a watertight seal, or indeed you can get over-the-counter swim plugs. You can even get custom made swim plugs from your audiologist where they take an ear impression, and using that cast of the shape of your ear, we can then make custom swim molds. And thankfully since then they haven't developed otitis externa. And that, one of the questions I get asked, or some of the comments, is that some viewers say that they get their water in the ears regularly and they've never had an ear infection, and that's true. So I'm not saying that everyone who gets water in the ear will develop an ear infection, but it is a trigger. I think there was some research that suggested about 5% of people develop otitis externa, which is an infection or inflammation of the outer ear due to water ingression. And that's because, several things. Basically, water increases the pH level of the ear, so the ear should be mildly acidic, and the introduction of water can make it more neutral or even alkaline in pH. And at those pH levels, you can get more pathogenic bacteria that enter the ear canal and colonize it and leads to an infection. Obviously, fungi also enjoy dark, warm, moist conditions, which the introduction of water can provide. Also, water itself, even tap water, can harbour a bacterium called Pseudomonas aeruginosa, which is a gram-negative bacteria, which can lead to an infection, particularly in patients who are more elderly, immunocompromised, or indeed diabetic. Another thing that water does, it leaches away the outer layer of wax and natural oils and sweats that we produce. So a bit of wax in your ears is good for you, and we all generally have a thin lacquer of wax that lines the ear canal, and particularly hot warm water will kind of leach that away, which then exposes the underlying skin. Now, the importance of those natural oils and sweats is that not only are they acidic themselves, so they help create this acidic pH level in the ear, but they protect the underlying skin, so it's a hydrophobic layer, and it helps the underlying skin, so the epidermis layer of skin, retain its natural moisture. So it provides some lubrication, and in the absence of that thin invisible veneer, if you like, the underlying skin is actually hydrophilic. It likes to absorb water, and it can overabsorb, and the individual skin cells, the corneocytes, which form the epidermis layer of skin, then overhydrate, swell and burst, and it breaks down the outer epidermis layer of skin. So you get maceration of the skin, which then can expose you to more infections. So some people may never have a problem, but it's difficult for me to, almost impossible really, to say who will and who won't. And even for someone who hasn't had any issues in the past, which I've had patients attend say that, well, they've never had issues in the past with getting water in their ears, but then all of a sudden, if the environment of your ear changes and the conditions, your immune system, for example, as well, you can then be prone to it. So just clearing that, the patient's got a really narrow bendy ear canal. They've got these whiskers of hairs at the entrance. Some of the wax is quite mushy, so I used a bit of drops to remove it. So we're just now peeling away some of this drier wax and skin that's lining the posterior. So when we say posterior, the back part of the ear canal, and it's quite medial towards the eardrum, so the posterior medial aspect of the ear canal. So we're on the bony, sensitive part, so we're going to be careful. We also then peel some dry wax and skin from the attic region of the eardrum. You'll see that in a moment. Then they've got this little widening, this basin in the midsection of the ear canal, a region called the pars media. So the underlying skin, there's no ulceration, so there's no underlying exposed bone. Whenever you've got a widening, particularly if it's localized, you've got to be wary of external auditory canal cholesteatoma, which is a dead skin cyst, which is invasive. It will start chewing away at the local structures, or a benign osteonecrosis. If it's a more global widening, then you're going to be wary of a potential or previous keratosis obturans. So this patient possibly has got a bit of benign osteonecrosis, and that's where the floor of the ear canal, so the base of the ear canal, the bone there is starved of the blood that it requires to kind of keep itself healthy, and as a result the bone starts to die and decay away, so you get necrosis of the bone, and it can also lead to sequestration, so separation of the bone. And patients who suffer from hypertension and who've had radiotherapy, for example, in this part around the head and neck, because they can damage the blood vessels, are more prone to it. Also, patients who take bisphosphonates, I think that's how you pronounce it, for osteoarthritis, I believe. So bisphosphonates inhibit the function of specialized bone cells called osteoclasts. And what osteoclasts do, they break down the outer layer of bone and kind of almost recycle it. So you then get other cells called osteoblasts, which rejuvenate and reproduce new bone. So the bone in our body is continuously recycling itself, and it's quite a useful process because quite often the surface of the bone may be a bit infected, you may have a bit of bacteria, it may become more fragile. So by recycling the outer layer of bone, you're getting away with any potential harmful bacteria, fragile aspects of the bone, and then you have new bone that's forming underneath. But bisphosphonates inhibit the function of osteoclasts, which mean the outer layer of the surface of the bone becomes more fragile, so it's more likely to separate. It can happen with the TMJ, the temporomandibular jaw joint as well, patients who take that particular medication. So I've managed to clear all of it. There's a few fragments of dead skin in there. There's a bit of dry wax just hidden away. You can see it's hiding, trying to not get my attention. So I've just managed to get around the anterior recess, pull that away. So guys, just to let you know, we've launched our next clear wax, earwax removal training course. I've just been busy upgrading the systems to incorporate the new iPhone 16e, which we're more or less done now. So I've got a training course already that's fully booked in May. I'm also got one in kind of early mid-June where I'm training an NHS department. But we've just launched another day on Friday, the 27th of June. So I'll just repeat that, Friday, the 27th of June. And that's going to be based in London. And that's just with the wax scope. We're just delaying training with the endoscope at the moment because people do really struggle to use the endoscope. I know sometimes we get comments trying to advise that I'm not doing my job properly or I don't know what I'm doing, but believe you me, an endoscope is not an easy thing to use. It takes a lot of skill, dedication, and just with the introduction of the new iPhone 16e, it's a bit heavier. So I'm just delaying that for the moment. With the wax scope, it doesn't really make a difference because you hold it in a different way. So the additional weight doesn't actually make any much of a difference, if any. So I'm just focusing on the wax scope at the moment. So this is the patient's left ear. The wax here, it's a lot drier, it's firmer. Tried to use forceps at the beginning and managed to get some away, but it was cutting through. They've got this bumpy ear canal. And once I removed this layer here, there was a thick layer actually embedded on the eardrum. So I'm using the right hand side of the endoscope. I'm pushing the first bend to the right, and I'm also resting the right hand side of the endoscope against that first bend, so it helps to stabilize the endoscope, and it also stretches the ear canal, so I can get the instrument in without stretching open the ear, because they have got quite a bendy, narrow ear. We wouldn't be able to get the instrument in. And I'm also then going backwards and forwards, particularly when I'm working close to the eardrum. So your endoscope hand is doing quite a lot, and you hold the endoscope using your non-dominant hand, because your dominant hand needs to be holding the instrument to safely remove wax, because you have more fine motor control there and stability. So using an endoscope requires a lot of bilateral integration and coordination between both hands and also your eyes. If only all ear canals were large, straight, and non-bendy, it'll make using endoscope a lot easier. So I think I actually reverted now to the 16 gauge. Now, the 16 gauge suction tip has got a smaller diameter, a lumen size, than the 14 gauge. The 14 gauge, historically we call it the Zollner suction tube. But it's quite a dry surface, and although the 16 gauge is a smaller diameter, therefore on paper less suction power, you're able to get a better suction seal with the smaller suction tip. There's less chance of not getting a seal because it's smaller. So inadvertently you can generate more power using the 16 gauge. And you can see some of the eardrum there, the blue tinge between 10 and 4 o'clock. So you can see half the eardrum now. So this is actually on the eardrum. So when I was removing it, I just advised the patient they may just feel something coming away off their drum, but they were very still. They didn't feel a thing. Again, I don't want to apply too much pressure, because if I apply too much pressure with the suction tip, we're going to be pushing this up against the eardrum and the patient will feel it. So I'm just kissing the surface, generating some suction power, and then slowly coming away, just as you can see here. And some of this is stuck in the anterior recess. As I was coming away, I think I lost the suction grip there. I'm just going to go back in. I have slightly sped up this video. Hopefully you won't be able to tell. I think I could tell at the beginning of the video, just to get it under the 15 minutes, because I also upload the videos onto LinkedIn so my colleagues can see. But on LinkedIn, there's a time limit of 15 minutes duration of videos. So this is some crusted skin at the top. Always want to try and remove this because we just don't know what's behind this. Could this be a cholesteatoma? It's not a cholesteatoma, I can assure you, but you just don't know. And a cholesteatoma can form in the attic, and quite often it can look like this, some innocent dry wax and skin, but it can also appear in the posterior superior quadrant. And what I mean by that, now, the way the patients position their head, this eardrum is not as it normally is. It's kind of rotated 90 degrees counterclockwise, or what we call anti-clockwise. But here, if the patient tilts their head back, it'll be between north and east. So as the patient's ear is in this orientation, the posterior superior quadrant is between west and north. So they're your hot spots for a cholesteatoma. And sometimes it can just look like innocent dead skin, and you reveal it and you can see the pathology. Just going to mop up some wax and skin, because they had a widening on the other side. I just want to make sure there's nothing sinister here. Recently, or for a while actually, sometimes you remove this and you can see some exposed bone. This is a bit more mushy, so I've got to be really careful. I think there's a little bit left behind, but I'm confident there's nothing behind that. I got most of it out. There's nothing around the edges. Nice healthy eardrum. Well, I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.